Welcome to Candidly COVID-19 and Endo. I'm Diana Falzone, as well as relates to other illnesses such as endometriosis. We've gathered some great minds today in varying medical fields. Today we have Dr. Tamer Seckin, the EndoFound co-founder and associate professor at Zucker School of Medicine at Hofstra/Northwell. Dr. Joseph Vinetz, an infectious disease doctor at Yale Medical School. Dr. Tamer Seckin, medical director at Shady Fertility Center. And Dr. Laura Payne, director of the Clinical and Translational Payne Research Lab at McLean Hospital/Harvard. Welcome. Thank you all for being here today.
Thank you.
Thank you.
Thank you. So I want to start with Dr. Vinetz, our infectious disease doctor and expert at Yale Medical School, and jump right in about what exactly is this novel coronavirus, COVID-19?
So it's COVID-19 is caused by a virus called SARS-CoV-2. That's a technical term, but this is a virus that's never affected humanity before, which means that everybody's susceptible to it. But different people have different responses to COVID-19 disease, ranging from asymptomatic all the way to dying from respiratory and other illnesses. Most people, the vast majority, do just fine. Many people may even be asymptomatic after an infection. When we see people in the hospital, they take two different directions. Either they go through an illness where they need some oxygen and then they get better, regardless of whatever medications we give them, because we don't really have any good ones. Or sometimes people go to the intensive care unit. The people that are at highest risk for going to the ICU are older people, really starting at age 70, when there's about a 10% risk, and over 80, there's a 15% risk of dying. Younger people are not immune to those effects. It just happens in much smaller numbers. Associated illnesses that we know lead to worse outcomes include large obesity, really substantial obesity, hypertension, underlying heart disease, and severe lung disease. It's not so clear if people with cancer or HIV or people on chemotherapy or other diseases are predisposed to worse infection. We just don't know the answer to that yet, but it's not obvious. So this is a virus that kind of acts a little bit like the influenza virus, but it has big differences. It's not mutating substantially like the influenza virus does, which is good if we think we can make a vaccine against it. Though when you see in the news the virus mutates, that only means that it has a molecular clock, so we can figure out where it's coming from. That's, but it's not mutating in terms of becoming more dangerous or less dangerous or evading the immune system. It's just, it's sort of what we call neutral mutations. That's not anything that we know we should worry about at this time.
In terms of its how contagious it is more contagious than your typical flu.
It is far more contagious, and we're only now learning how much more contagious it is than the flu virus. There's a statistic which is too technical called the R0, but basically how many other people can somebody with, say, influenza virus, how many other people can they infect? An influenza virus has somebody infected with a flu will infect about 1.2 to 1.5 other people. However, the COVID-19 virus seems to infect anywhere from 3, 4, even 8 times as many people as the flu virus. And that's because of this asymptomatic phase. And early in that asymptomatic phase, people can have 100 million viruses per milliliter of snot, if you will. And so that's a lot. And there's even videos that you can find on the internet or on YouTube or on New England Journal that shows even when people are talking, that people are expelling virus around them. And so even when somebody's asymptomatic, they can be spreading the virus just by the sheer act of talking. The first hint we had of that was with a choir practice in Washington State, where there was a whole big cluster of people that got COVID after a choir rehearsal, even when people stayed 6 feet away from one another. And so this is a virus that's more contagious, probably because we have so much more of it up in our upper airways, and asymptomatically so.
It also is not seasonal. There's been some myths out there that it's a seasonal virus, but this virus is not going to go away during the summer months, correct?
We don't think so. It's too early to say if it's, quote, seasonal. People, because of our president, people said it must be seasonal. It's going to go away in the warm months, spring, summer ahead. Unfortunately, I don't think that's going to be the case. In the southern United States and in the southern hemisphere, despite being very warm, there's been a lot of spread of this virus. So, unlike influenza, which seems to be very seasonal, where you've got it during the winter months, kind of goes away in spring, summer, and comes back in the fall and winter again. We think that it's not going to act that way. So instead of having a second wave of transmission in the fall, I believe that without doing something, and that doing something we can talk about more,
Right.
is going to have wave upon wave of new transmission.
I do want to get into the second wave that's most likely going to be this fall, as you mentioned, but I do want to talk to Dr. Singer as well, because he actually was tested positive for COVID-19. Dr. Singer, what was your experience like, especially in the early stages of COVID? How did you know that you could possibly have this?
So thank you for having me. In the beginning of March, I was seeing patients, I'm a fertility specialist, so I see a lot of patients every day, anywhere between 30 and 40. And in the beginning of March, I started having a dry cough and a runny nose. And I thought that, maybe the common cold. I felt completely fine. And a day or two later, the symptoms really went away. And then 5 days later, I started suffering from muscle ache and headache. And the next day I had fever, and I went to an urgent care, and there were starting to be some cases that were reported to New York. There was really one case on March 2nd, and I was a couple of days later, and they were not testing at that point. And I had an X-ray that showed a very mild pneumonia. Started antibiotics, as most people would recommend, and then 2 days later, really had shortness of breath, and that's what sent me to the emergency room. And like Dr. Vinetz said, I did not know that I was in contact with anyone who had COVID before that. I didn't travel to China. So those were the guidelines initially to test for COVID-19, which we now know are, very vague or very minimal criteria.
Mm-hmm. Did you have any kind of medical interventions to help you get through COVID-19?
Yeah, so I went to Long Island Jewish Hospital, and being a faculty member up until recently there, and being an associate professor, they really were on top of research, and they came up with this couple of case reports and studies from China regarding the chloroquine, or now they're talking about hydrochloroquine, and they asked if I will be willing to accept that medication. They started me on antibiotics, Azithromax, and I did get the chloroquine for 5 days, along with the Azithromax and oxygen, which was the main symptom, shortness of breath. And whether it helped or not, we don't know. But being 43, no risk factors, no medical conditions, eventually after 10 days in the ICU, I was able to be discharged, and now get immune and check the antibodies and have a very good titer. So I'm very happy that that's how it went down.
Well, thank goodness. I'm so glad you're well and that you were able to make a full recovery. And that actually brings me to another question for Dr. Vinetz regarding immunity, because there hasn't really been enough time to figure out what immunity looks like. Is it short-term immunity? Is it long-term immunity? Have we made any advances in terms of our studies regarding this?
We don't really, to be perfectly honest, we don't know. So antibodies don't necessarily mean immunity. We hope so, but we need to show that that's true. And there's a couple of different ways. First thing is you have to show the presence of antibodies. The next thing is you have to show those antibodies neutralize the virus. And to do those, really those are experiments, you have to have a high level biosafety level 3 laboratory where you're growing the virus and you add the patient's sera to the virus and then see if it can infect respiratory epithelial cells, the cells that line the respiratory tract. And if that works, you say, oh, that's good. Are those antibodies actually effective? And what we're looking there is at IgG antibodies. Those are important antibodies that reflects a very specific immune response. But the immune response that really matters for protection is another antibody called IgA that gets into the respiratory tract and prevents the virus from latching onto those cells in the respiratory tract. And at this time, we have no way of really assaying that or looking at that. And so the only other way of finding out if those antibodies confer protection is actually looking at people like Dr. Singer, sending them back into the hot zone and seeing if they get infected again. Not a very ethical experiment to do, I might say. Right. So, but you can do that on a large scale, but it's extremely expensive. You'd have to have thousands of people to detect that rare event. And that's literally would be a $100 million study. We're not really prepared to do that.
At this point, there's been a lot of controversy around medical interventions, what works, what doesn't work. Is there anything in the data at this point with research that's saying that this certain medication will help alleviate the symptoms or speed up recovery for COVID?
So it's important to think about this disease in two ways. The early stage where the virus is replicating, and the late stage where it's the host response, a person's response to the virus. Dr. Singer described beautifully the natural history of that infection. He had clearly upper respiratory symptoms that then progressed into pneumonia and the need for oxygen and ICU care. That's the inflammatory response. We do not have an antiviral drug. I personally have seen no real effect of hydroxychloroquine, and I have seen about 25% of our hospitalized patients have to be taken off of it because it crosses the wires in the heart. That being said, we are the real way of figuring out, and as far as the inflammatory phase, that late phase, we think that interfering with interleukin-6 actually seems to help people, but we don't know that for sure. There's a drug called remdesivir, which has been tested. It's a drug from Gilead. I have no stock or interest in Gilead. It's a drug that was used in the Ebola virus outbreaks a few years ago. It wasn't effective, but shown to be safe. And then it seemed in uncontrolled, highly selected, and very biased, recently publicized studies from which I can draw no conclusions that it's helpful, possibly, maybe promising. Would I want to be on remdesivir? Sure. If I was getting very sick, but it's only able to be given intravenously, and right now can only be given to people in the hospital who are pretty sick or very sick. What we need is a drug that you can take a pill that would prevent people from going from mild illness, like Dr. Singer had, to getting hospitalized, or even better, in addition to preventing a hospitalization by reducing the amount of virus replication, a drug you could give out to large numbers of people, like a population, that would prevent people from getting infected to begin with. And that's a clinical trial that I've designed and implementing at the Yale School of Medicine and at Yale New Haven Hospital in the outpatient setting.
So that would be obviously a tremendous leap forward in terms of advancement of how to almost be one of the front lines of defense.
It would be a global game changer, and say, if we could find such a pill that you could take for a few days or a week, it would save literally tens of trillions of dollars. And so that's a pretty big game changer. The problem is when you do these clinical trials, and let me tell you, I've done a crash course in how to write them up and get the approvals, and it's complicated. And I've learned it all in about 2 weeks. I'm a quick learner. And what do you really need? You need to have boots on the ground with people taking samples, gathering data, doing proper informed consent, storing the data, analyzing the data, and even designing the studies to begin with. And it's not all that much money, but you know, universities don't necessarily have large pots of money just to throw at these things, especially these days when there's a lot of problems. So we've designed we're shovel ready. I have a company in Japan ready to ship 13,000 pills to me once our institutional review board approves the study, which they're already reviewing. And then we have to get a license from the FDA, which I think they'll give us in a day or two, because this drug in Japan is already approved in Japan and in Europe. So all of this could happen literally in a couple weeks. But now that everything is all set up and shovel ready, we need to actually buy a few shovels. That's where we literally are right now.
Yeah, but
and I think it's going to work. I give it a 50-50 chance, which is pretty darn good in the clinical trials world.
the pill you think is going to be effective.
Yeah,
And
I think so, but that's why we test it.
and this would be,
And sorry, let me just finish. It's a placebo-controlled, randomized, and blinded clinical trial. So we're going to recruit, starting with about 120 people, divided into study drug or not. Half of them get a study drug, half of them get a placebo, and we don't know who gets what. And the participants don't know who gets what. But we will have an answer in a couple weeks, and for those individuals. And so and then that would be a game changer. The faster we can enroll patients into this protocol, into this study, the faster we could have a result. And then step up the use of that drug by getting real FDA approval. And then Tony Fauci can brag about how wonderful the NIH is, because he's the best.
that sounds, I mean, that's hopeful. That's promising. And we've been not really seeing a lot of glimmers of hope with coronavirus and how perplexing it is and hard to understand. Now, this pill would be something that would be right now as we wait for a vaccine, which could be a good 18 months or longer away.
That's correct. Vaccine development, I don't know, I should give some others a chance to talk, but vaccine development, we know what the protein is that we want to target for a vaccine. It's called the S or spike protein. But the big problem is we don't want a vaccine that makes the disease worse. And that's something that can only be tested by very careful clinical trials. And that's why you can't accelerate this stuff. And the reason I say that is the older people are that get bad complications from COVID are the ones that have the highest antibody levels. And so we don't know why that is. Young people that have mild disease may or may not have any antibodies, even though we know they were infected. And so there's something, and I have a whole bunch of scientific hypotheses, and I can get my nerd on if you like, but I won't make you suffer with that. But if that's true, then a vaccine that induces the wrong kind of antibodies could make things worse rather than better. And so we cannot rush the vaccine development. And that's the real reason.
It makes a lot of sense. Now, Dr. Seckin, we talk a lot about comorbidities with COVID, underlying complications that people might have. Would you consider endometriosis to be an underlying health condition when it comes to this novel coronavirus?
But before that, I'm very curious. May I ask a question? Maybe I can get an answer. Can I have a question to Dr. Vinetz? How about the serum of the patients who have had the immune plasma therapy? I mean, it does make sense. I think from Texas, there was very good reports on that. What's your experience on that?
I don't have any direct experience, but I have a couple of thoughts. The convalescent plasma for sure works with Ebola virus, or you can use monoclonal antibodies with Ebola, and that's because the virus is in the bloodstream and goes everywhere in the body. COVID, the virus, is not in the blood. It really isn't. And so unless you can get antibodies to the cells that are affected by the virus, I have some concerns. I'd love to see it. We need to see controlled trials. And I'm worried that there's at least a possibility of enhancing immune enhancement. And so so I can't give you an opinion, but I worry about anecdotes that aren't controlled, again, for the risk of making worse disease. So those trials need to be done. They're ongoing. Mayo Clinic's doing one, Johns Hopkins is doing one, and needs to be done very carefully.
How come Japanese have already a drug, antiviral drug? Is it something being used for something else? It can't be against COVID.
It is
obviously.
not. It's used for chronic pancreatitis.
There you go.
But it turns out there's a common mechanism.
But there's something with this virus's virulence that causes intravascular coagulation, like you said. I mean, a well-known actor lost his leg in LA, we heard. He had severe DVT and he had to get his leg cut off. I mean, this is not your routine influenza virus. There's something else happening here, and people have sudden pulmonary bleeding. It basically ruptures the vessels and everything. So we have to cross our fingers. I think we're gonna hear more from Dr. Laura Payne, how we have to deal with it later. So let me get back to the endo. If I can have your question one more time, please, so I can be focused on that particular question.
Of course.
How would endo patients would tolerate this difficult time with respect to pain? Is that right?
Yes, we can address that, and then we'll go back to the original one too.
Well, look, as you all know, endometriosis is a very unique disease, which is characterized by inflammation of pelvic or floor with against the endometrial lining. There is significant pain these patients suffer, and everybody's endo is different, and everybody has a different way of dealing with their pain. In that regard, it's difficult for me to tell, abstain from this and that. This is hard time. One thing I would beg is don't go to emergency room you all know that you won't go to emergency. Please use what you have and what works at home as far as medicine to alleviate your pain, obviously with non-steroidal analgesics and obviously at times more powerful pain medication. I mean, frequent bathtubs and massage, a lot of other things would help certainly. I don't have a magic answer. Hopefully your doctor knows that you're suffering. When the time comes, they will see you and get your treatments going.
And Dr. Seckin, just to ask a little bit about that, right now many non-essential or deemed non-essential surgeries are not happening because hospitals are being used for COVID. But when should women look out for the signs where it becomes medically necessary, especially under the umbrella of endometriosis? Is it something like an ovarian cyst about to burst? When do you seek hospitalization? Well,
I think it's good to review this again. Basically, most common emergency with endo patients could be actually ruptured ovarian cyst, especially if it's a big one, it ruptures. It does cause acute abdomen. And in my experience, if I have a patient with a ruptured cyst with a known endometrioma, I would do everything to help that woman and clean things out so it doesn't really disseminate all over the peritoneal cavity and causes more problem like obstruction and causing more adhesions and everything. Apart from the ruptured endometrioma, obviously, endo patient may suffer from ectopic pregnancy, like Dr. Tamer Seckin would get into it. Sudden rupture of a tube would be an emergency. Obviously, rarely, but we see a lot, the pulmonary endometriosis, thoracic endometriosis, where you have a collapsed lung, sudden short of breath, especially at the period time, particularly, we call it catamenial pneumothorax. That's an emergency. similarly obstructed or bowel that is progressing into obstruction, or some sort of ureter obstruction causing severe pain and fever, obviously those needs to be surgically intervened. That's all I'm going to say on essential. Otherwise, patients should not also suffer in pain. They are not in the same classification as plastic surgery or elective hernia surgery. These are an urgent group of patients. By patient, we have to look into and put it on the schedule. Hopefully, schedule is going to open after May. We're hoping.
We have a couple of questions I also would like to address. Someone is asking, where's the question about comorbidity? If there's any kind of component with endo, is endo being considered an underlying health condition when it comes to COVID?
I can try and answer that maybe.
Okay.
So I think that there's obviously a lot of overlap with the inflammatory response, and just like Dr. Vinetz mentioned, anti-interleukin 6 may be a potential treatment in the second phase of the disease, not the initial viral symptoms, but rather the second phase, which is more difficult and gets you to the ICU or even intubated at times, definitely is related to the inflammatory response. The issue is that most of the patients that are sick or dying are really patients that are in their 6th, 7th, and 8th decade of life, and even beyond that. And those are not usually the typical endometriosis patient. So Dr. Seckin will take care of patients who are usually 20 to 50 years of age and still menstruating. And as a reproductive endocrinologist, I can tell you that some of the treatment aimed to treat endometriosis is really to block estrogen or estrogen receptors and so forth. So I think that it will take time until we have enough patients that are young and are also suffering from endometriosis, and it also happens obviously to be females, which we know men tend to contract COVID a little bit higher than women, until we have answers. So we need to be honest. We think that there is correlation. We think that patients with endometriosis who suffer and have stage 3, say stage 4, have issues with obviously an inflammatory response. But from there to assume that they have a predisposition for COVID, I think it's a big gap to take.
Well, thank you.
One thing I could add on this, if I can, certainly anti-estrogen regimens and prolonged for pain purposes, even though in lab you cannot show, but overall research has shown they have immune suppressant effect. My colleague, Dr. Singer, may not agree with me, but a prolonged, long-term anti-estrogen or even anti-androgen, they work the same way, studied in prostate cancer patients. They do have bone marrow suppression effects. So it's bear in mind, I mean, I wouldn't put in this critical times, I don't think anybody should be on long-term Lupron treatment. That's the only thing I can really interject here. This is something I just looked up recently. It's not something I paid attention all the time, but this is a time you really refresh your knowledge and go back to books and articles, and it's been there.
I would like to have Dr. Laura Payne also interject here, because there's a lot of different levels of pain. It also is dealing with a lot of anxiety of you can't go to the ER necessarily for something that's it's moderate to severe pain, but it's not necessarily life-threatening because there's too much of a fear of contracting this virus. So how do you psychologically deal with this anxiety that many people are feeling right now?
Well, I think that one of the biggest things that we have to try to implement is trying to keep a routine and a sleep schedule and all of the things that are kind of the baseline for good mood, lower levels of anxiety. Now, that doesn't mean you're not going to experience anxiety, but having some routine is going to help a lot. And so that means, when you're not in a particularly acute pain episode, you may generate a list of different activities that you can do throughout the day. And it may be some exercise. It may be a 5-minute meditation that you find online. It may be doing something creative. things that you're going to explore and have on a list, because when you're in pain, you're not going to be able to think of those things. So keep in mind the routine, not allowing yourself to oversleep, because I think once the sleep schedule starts to change, that is also the recipe for anxiety and depression. This is a really hard time because basically, this whole situation is the foundation of anxiety. It's saying there's something really bad. We don't know how to predict it, and we don't know how to cope with it and when it's going to end. So it is 100% normal to feel very anxious right now. And particularly if you have another health condition such as endometriosis that you want, to be able to get care for. Specifically for pain, I would think about some different activities that or coping strategies that have helped you in the past. Again, don't try to think of this when you're in an acute, intense experience of pain. So, it might be massages, it might be warm baths, it might be stretching, or it might be not stretching. It may be some good distracting activities. And come up with a variety of different things that you can pull from when you're in, an intense pain episode.
No, that seems very helpful, because like you mentioned, we don't know when we're going to be out of the quote unquote woods. Dr. Vinetz, they're making a lot of guesstimates here. Every month, governors are saying, okay, we're going to end social distancing March or May 15th, and then it could go on. Is there anything within the scientific community that's indicating when it will be safe to go back outside?
So let me rephrase it a little bit. What can we do to prevent this virus from going through more of our population? Mm-hmm. So right now, not more than 1% of the entire country of the United States has been infected with this virus. So what makes anybody think that when we start relaxing what we're doing now, we're going to be magically immune to this virus? That's just not conceivable. But there's a couple things. One is early on, CDC and the Surgeon General, and I parroted their remarks, said, don't wear masks. It's not going to help you. Well, that's true. It won't help you from getting infected. But if everybody wears a mask in the public setting, there's a lot of information out right now that shows that even if you're asymptomatically infected, you're not going to infect other people. The risk is much, 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 much less. So I can imagine that simple recommendation of wearing, I don't think I have mine here, I do. Having a simple surgical mask like this, properly applied, and you have to stick it around your nose, and nobody wears it right at the grocery store or outside. Half the people I've seen don't wear it correctly. That's probably going to knock down 99% of transmission. That's something that we in the United States don't like to do. It's antithetical to our sense of individualism. And wearing a mask like this is a thing that we do for collective good. And so we have to change how we think about it. Short of that, there's no way, I think we're going to get into a Mad Max scenario, if we're stuck indoors too long. And being stuck indoors for this group of endometriosis affected people, I won't call patients, even though the word patients means to suffer, people that happen to have endometriosis and pain. It's even worse when you're sitting indoors, isolated, and all you think about is something internal, inwards looking. We got to get out, and everybody's feeling this way. So we either need a pill or a vaccine, basically. And the vaccine's far off. A pill could be sooner. And a mask is available right now. These are easy to make. This is just some recent thinking, but if we could reduce the transmission by 90%, 95%, then we could feel safer about going into public places. So it won't protect you from an infection, but it'll protect others from being infected by you if you're asymptomatically infected, and even talking. So talking expels the virus. So I see a combined set of, we've only learned this recently in the last couple weeks, and I think that's where policy will go.
Well, I've been hearing a lot about the second surge, and infectious disease doctors have said publicly that it could be in the fall, but aren't we still, the virus is still present. It's still in the environment. Like you said, it isn't going anywhere.
It's still in people. So people are the source of transmission to other people. I don't think the environment is. That's really very different from all sorts of other infections. But it's in people, and it's going to kind of meander along, and it's going to, if we don't do something to control person-to-person transmission, then it's not going to wait till the fall. It's going to happen in June, in July, in August, and then we'll have to panic again and not really use what we've learned during our last 4 to 6 weeks, and I call it timeout. This is massive adult timeout. It's not that much fun.
No, it's not that much fun. And Dr. Laura, we're getting some panelists or some viewers who are saying this is such a serious conversation and it's so scary. And it is scary. These are unprecedented times. No, in any of our generations has had to quarantine or self-isolate or worry if they're going to touch their mail and get something, or go to the grocery store and get this disease, or carry it to a loved one. By no means do we want to scare anyone. It's about informing. And I think knowledge is power, especially in a case like this. But Dr. Payne, what advice do you give to people who really don't want to hear it anymore, that they're just overwhelmed with the amount of information that is out there?
Yeah. First tip, I would absolutely say limit your news watching or reading. Maybe limit it to 10 minutes a day. You can check in, kind of see if there's any updated guidelines, any major changes, and then put it away. Because there is nothing helpful that's going to be coming from headlines about, this death rate, or, how easily it's transmitted, how much it lives on plastic. That is not helpful. So I'd say really limit your news watching. And then I would say, we want to try to behave in a non-anxious way, and that will actually help our anxiety. So it's using kind of the rational part of the mind to know what the recommendations are, know what the guidelines are, follow those. And if you find yourself feeling very anxious and saying, well, now maybe I should, even though I just wiped down my hands and, my doorknob, do I need to do it again? Try to limit that behavior, because the behavior will also kind of inform how we feel. And so if we try to behave in a calm way, even if we don't feel it at that time, it will actually help over time. So you want to follow all the guidelines, but really try to not go beyond that, or kind of, you read an article here, read an article there. I would say that is probably one of the best ways of managing anxiety. And also looking, for example, at the information that Dr. Vinetz and Dr. Singer and Dr. Seckin presented, where it is scary, and when you look at the news, it does seem like everybody has it, or is about to get it, which is not true. It is, obviously a big concern, but when we look at the data, and kind of the rates of seriousness of illness, it is an issue, but the chances are, if you don't have certain risk factors, that it's less likely to be, a really life-threatening issue.
And there's a lot of anxiety that's circling around fertility treatments. Those I went through IVF. It's very much about your cycle being timed to the exact moment, the exact hour. And it's been very, very sad to read about people having to cancel their cycles because they haven't been able to get to the clinics. Dr. Singer, we have a question because Governor Cuomo apparently deemed fertility essential. And someone is asking your perspective, Dr. Singer, on women starting treatment again, especially women in New York City, which is the epicenter of the coronavirus. Would you recommend they start right away or wait it out a bit until the pandemic settles, which we just heard it's not really going to settle anytime soon?
So that's an excellent question. And, you know, Governor Cuomo and Howard Zucker, who's the medical director in New York, really considered fertility, as you mentioned, as a necessary treatment, just like pregnancy and treatment for STD and termination. Hopefully in the very near future, like Dr. Seckin mentioned, there's thoughts about 2 to 4 weeks before elective surgeries, or what's considered elective, will be resuming as well. So there's some good news. We really took a break for about 4 weeks in treating just an elective fertility patient. We only treated patient with cancer or impending chemotherapy treatment and did fertility preservation. But as of yesterday, or as of Friday, we resumed our full capacity fertility treatment and saw other centers. So I would say to the viewers who are not in New York, and in New York there's several centers that already resumed their activity, and we can divide it into 2 types of patients. Those who have endometriosis and are single and have stage 3, stage 4, low ovarian reserve. I think the uncertainty adds to the anxiety and the depression. And when will I be able to actually address my issues and freeze my eggs, or, you know, plan my future fertility? And I think that is coming very soon. And we're doing already elective and medical egg freezing, and most centers will follow. And the second type of patient is the couples who are struggling at home and have blocked tube or low sperm count, or could not really just have a easy time conceiving. You don't hear Dr. Fauci or Dr. Birx saying, don't try and have sex, don't try and get pregnant. There's a lot of reassuring data. You know, babies are born every day in Manhattan and all around the globe, but with good reassuring data. So I think that going back to the basics, getting ovulation prediction kits at home, you know, timing your intercourse. It's also exercise, like Dr. Payne mentioned. So that's your 5-minute exercise right there. And checking the sperm or checking your fallopian tube. You can do the fertility workup. You can check your FSH. You can go to your doctor and do your AMH. The lab testing centers are open. I think that having a plan in this time of uncertainty will help. So you know that you're in May or in June doing all the workup and you're starting your fertility treatment a month later. And I acknowledge that a lot of the patients are coming from different countries and different states, and they may not have the accessibility that we have in Manhattan. So really go back to the basics, have a lot of sex if you're interested in conception, and try to time it so it's the right time of your month.
Thank you for that insight. Thank you. Dr. Seckin, some viewers are asking too, when you think hospitals might reopen for endometriosis excision surgeries?
Yes, I am also seeing those questions. I apologize. There are tons of questions there we cannot answer, but many questions are revolving around, and some of the names I'm very familiar who are asking from overseas, some colleagues. The question really specific to say, yes, right now emergency is stopped. It is from Dr. Usta from Istanbul. He's asking, yes, after 3 months, what are we going to do if the virus is still around? The problem is, unfortunately, the virus will be around, and this public paranoia that we're going to live with is going to last much longer than we were introduced to the virus. And we will have another lifestyle that we will distance ourselves. We will apply strict protocols in the office. I'm not sure how dependable it will be, these immune tests, whether, hey, I'm immune now, I can come, or can I reinfect again, or is there still virus going to start the second break somewhere else? We don't know these things. But at one point, I think when the curve really goes downwards, we will all take risk and try to forget and move on with our lives like we're doing every day. I mean, we're not stopping flying because some weird accident happened somewhere. I hope things don't come to that level. But the bottom line is, this will be forgotten, but it will take a long time. I think, though, elective surgeries, endo surgeries will resume again with strict protocols. and we will distance, we'll take measures. All the ventilators have to be cleaned well. The hospital should be a very safe place to go. It's hard to go to hospital when you know there are still 200 COVID patients 2 months later, you know, or even 100, even 10. So these are the issues. Every hospital may be obligated to report how many cases they have, or there are completely COVID-free hospitals. So there are lots of new terms and new introductions we're going to live with every day. So get ready. It's going to be a roller coaster.
Yeah, I want to echo Dr. Payne, especially she says, don't look at the news too much. So this is true. But what I can gather, I'm not a specialist in women's health. I'm a infectious diseases crosses all specialties. And that's one of the strengths of what we do, but it also makes us sometimes a little bit ignorant. So I don't know anything about immune compromise or inflammatory states in endometriosis. But what I can say is that women affected by endometriosis are people that want to take control of their lives. And the anxiety is when people think they're not in control of their lives. And so one of the questions came from a participant who's like, can you guys lighten it up a little bit and give each other some mutual high fives? But what I can say, what I and many doctors focus on is what can we do? And I would extend that into what can all of you do to kind of manage this anxiety, and collectively, what can we do to really reduce this temporary plague? This will pass. It's temporary. We've only been in timeout for a month. It feels like forever. We're worried about the future. There are different and scalable ways that we're going to be able to overcome this. Fortunately, many women with endometriosis are in their fertility years. They're not elderly. They're usually women who are cycling. And women are less susceptible to severe disease than men are. So yet one more way that women are superior to men.
Maybe one more comment, because I see some follow-up questions. So, you know, when you resume fertility treatment, whether it's for egg freezing or IVF or IUI, things are not going to be the same. We do a lot of what we do now via video conferencing, all the new patient consult and the follow-up consult. And a lot of the consult I'm doing recently is just to talk about the basics about prenatals and what you can do at home and how can you increase your chances, because there's a lot of anxiety to just come back to the office. Most fertility centers are outside the hospital. So Dr. Seckin is right. You have hospitals that became COVID units and you're afraid to just walk through their doors. And that will take some time. But our centers and other centers are remote and they're in the building. So when you come in, you're going to have only a 10-minute slot. You're going to have a mask on. We're going to send you a questionnaire the night before. Some of the protocols that are going to be implemented for endometriosis patient when they have surgery with Dr. Seckin, the staff is going to wear an N95 mask. They're going to have gloves. You're going to have interaction with just the patient who's drawing your blood, putting you in a room. You'll see me for an ultrasound. The whole interaction is about 10, 12 minutes, and you're basically going to limit the amount of people in the waiting area to try and minimize the exposure both to the patient and the staff, and to give the patient the sense of security and know that we're doing everything to minimize exposure.
I just want to say one additional thing based on a little bit of what Dr. Seckin was saying. About, when we pre-COVID, when we go out of the house, we don't think about all the threats and risks that we take. It's part of our mind's way of adapting. It's called the illusion of control. It allows us to function in our daily lives. We're not thinking about how likely we are to get into a car accident or the effects of pollution or all sorts of different things. And so there has to be some level of acceptance that living means you live with some risk. And there are no zero risk behaviors. Even staying in your house could be a risk for something else. So having some acceptance that this is a new risk and we don't know a lot about it, and that's why it's so scary. But we deal with risk all the time. And so trying to put it in some perspective can also be helpful.
I think the critical thing is really this affected all layers of the society, all mothers or single women, single mothers with one kid stuck in a house where they don't have their backyards in an apartment, and all the kids. I mean, even the parents can go out, the dogs can go out, the kids have to stay inside. I mean, it is a torture, and I could really sympathize with that agony, with the stress level and anxiety to where we're going. In that sense, we have to create more. Hopefully, the restriction will be relieved, so some degree of stress on the society will be alleviated. I mean, think about all these food lines we are seeing. Really, I mean, I'm comfortable in my house. First time everybody's in the house. I can have a sign here, please save me also, but overall I'm happy. But also I only know patients giving me a call stuck in apartments with no help, only one person trying to get food. It's terrible. We really have to hear each other here. I hope this is going to be over soon, but we'll see.
I think it's all about adapting and resiliency. And, you know, people say we're all in the same boat, but varying degrees. Everyone has a different battle that they're dealing with right now, whether it's endometriosis, trying to get groceries, fighting COVID, having a loved one who is fighting that virus. There's a multi facets going on here. And like you said, Dr. Seckin, we're all dealing with so much. This is a virus that's hit us all at our core. It stopped our normal way of life. Dr. Vinetz, we have a question about trying to help our immunity, any kind of immunity boost that people can do. Is there a vitamin that you would recommend? I've been hearing a lot about vitamin C in strong doses.
So the history of mankind is, can we take a pill to make us better? And the best pill is to go and exercise. Exercising is very clearly the best way of boosting one's immune system, or really resisting the bad effects of any infection, including COVID. So there is no magic pill. If somebody has a known deficiency, sure, you know, that should be fixed. But generally speaking, we don't really know of a lot of immune boosters. Other than stopping smoking, eat well, exercise, all those things the damn doctors, we keep repeating over and over and over. Those are the hard things to do. Pills are easy, but exercise and other lifestyle modifications, they really are harder. And that's just, I say that in as kindly a way as I possibly can. But I'm a direct speaker. And I can't tell you anything I don't believe.
Dr. Vinetz, there is a question about a reliable test for COVID. This is also coming from overseas. Really, what is the basis of these COVID tests? I mean, is someone testing antibody A or the other one saying antibody B? Which is reliable? We don't have the medical information yet to. What's your input on this, please?
There's two kinds of tests. One detects the presence of a virus, and the other detects the presence of an immune response against the virus. So the testing that we do to see if somebody actively is infected with the virus is a swab test that either goes in the nose or the throat or deep into the lungs. And that uses a molecular test called the reverse transcriptase polymerase chain reaction. Extremely sensitive test. It's still limited because who wants to have a swab stuck into their brain through their nose? Because that's what people tell me it feels like.
So that's not practical. What is the practical way of?
Oh, we do that all the time. That's how we diagnose it. And nobody likes it, and sometimes we have false negative results. Now,
The question comes whether if a patient is going for surgery, what is the reliable test to give the patient so everyone feels safe and the patient also feels safe to go on?
Well, many of my surgical colleagues are like, no, 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 we won't do anything till they have 2 negative swabs. So I had a patient who had a other infectious disease. She had a horrible, this guy had a lesion up his nose, and we thought it was cancer, so we thought it needed a biopsy. And so the ENT doctors would not take him to the operating room unless he had 2 negative swab tests for COVID, even though we had already had a negative. So that's that's individual. That's something called infection prevention. So there's a whole in hospitals. So only in hospitals, not really in the outpatient setting. An infection prevention staff member really is the one that can clear people for surgery. And there are safe ways of doing it. An antibody test will not be helpful. No anesthesiologist wants to intubate someone that has COVID in their respiratory tract. That's scary because that will infect everybody around them. So they want to know for elective surgeries, endometriosis surgery or a nasal biopsy or whatever, they want to make sure you're not infectious, and a swab test is the best way to determine that. So just one thing. In New York, there was a survey of 100-something pregnant women, and 20% of them were COVID positive with no symptoms.
Asymptomatic.
Crazy. Right. That was crazy.
Mm-hmm. That came from Colombia, Mary Dalton, yeah.
So we're looking So we're looking for a COVID-free healthcare institution, hospital. We're looking for COVID-free patients. Things are not going to be easily on the track. Obviously.
Oh, I don't know about that. I think that soon enough we're going to get a 4-hour turnaround time for a test in the hospital. No problem. And I don't think we have to worry about being COVID-free. You remember, during flu season, hospitals say if you've got symptoms of the flu, if you have fever or snotty nose or a cough, stay out. Soon enough, we're going to have rapid tests that we're going to be able to have a very quick turnaround that will make it very safe for people to be in the healthcare setting. I'm really not worried about that.
In your view, since it's been 2 years since the previous SARS, now we have COVID, again, that's a SARS, COVID-19. Will it be COVID-20 coming next year?
Now you're asking really good questions about science. So SARS-1, it turned out it was a very bad disease with a 10% fatality rate, and it was not very contagious. That was the beautiful thing for us. It went away. It's gone. It's off the face of the earth. It might be in a freezer somewhere for a laboratory, but it is gone for all intents and purposes. SARS-CoV-2, our new virus, is very transmissible and less lethal, which is a very bad combination. And so will there be another one? Nobody knows what the origin, what you're really asking is what's the origin of this virus? And are we going to get more and more and more of them? It's not going to mutate. I talked before. It's not going to mutate from what we have now. And these viruses only live in animals, and it seems that the SARS viruses only live in bats. It seems that it came out of China, not because of that wet market they're talking about, but there's a building up of circumstantial evidence, even published in at least 2 articles in the Washington Post, which is supported by even State Department cables, that there were some serious biosafety issues in China where very outstanding laboratories were doing experiments with coronaviruses right out of bats. So I have a personal theory. This is not official, but my personal theory is that there was a laboratory accident and somebody got infected with poor laboratory practices, inexperience, and poor training, and then went out and it was this magical combination of a high level of transmissibility and a fairly low fatality rate that led to this spread and the rapid spread.
You're not alone on that.
Right.
I can assure you.
Well, I talked to the reporter at the Washington Post, and he said, "Why are you scientists so resistant to this notion?" And it's because we don't want to have all work in science stopped by regulations that don't make sense. And I said to him, I'm on our biosafety level 3 safety committee now because I want to make sure that we can do work, but we do it safely with good training and in these very elite laboratories. And that is certainly possible. But the State Department was very concerned that in these Chinese laboratories, that high levels of safety were not being followed. So that threatened mankind with this multi-trillion-dollar plague that we have, that's killing our family, killing our friends, and really having such a huge impact on all of us. So we all have an obligation to be community-minded and understand while we need really good science needs to be done safely, but shouldn't be cut off. That's a balancing act. It's a great question.
Very strong point. Unfortunately, that's all the time we have today. Thank you for everyone's questions. I know there was many. There's a lot more about endometriosis and infertility, but I believe that will be addressed in an upcoming webinar that you'll all be updated on soon. And thank you to Dr. Payne, Dr. Seckin, Dr. Singer.
Let's give a high five. Thank you very much.
For all your insights. High five. Everyone stay well, stay safe, social distance practicing, and hopefully we'll be back in society again very soon, very safely.
Thank you, Diana.
Thank you.
And Dr. Payne, thank you for your very sage advice.
Thank you as well. Thank you.
Thank you, Dr. Vinetz.
Thanks, everyone.
Thank you.